Well, greetings everyone, and welcome to the EKG case for the week of October 14th, 2013. Well, this week we get to talk about something that I really enjoy talking about, and part of that has to do with the fact that I work in Baltimore. I don't live in Baltimore, but I've been working in Baltimore at University of Maryland or its affiliates since 1996. And for that reason, I want to spend some time talking about this. Now, take a look at this. This is dark field microscopy, I think, and if you know anything about visual diagnosis or histology or microscopy, or I don't know what it is, you know what this diagnosis is, right? This is syphilis. Now, what does syphilis have to do with Baltimore? Well, we always like to brag that Baltimore is one of the national leaders in terms of syphilis cases per capita. Believe it or not, it's something that we have bragging rights to. You got to brag about something, right? So every year we get our flu shot, we get a little extra penicillin and a couple of other things. We get a little extra Narcan as well. But anyway, syphilis is very common in Baltimore. And for those people that don't know syphilis, this is what syphilis looks like on the hands, primary or secondary syphilis. So what does syphilis have to do with electrocardiography, you may be asking? Well, it has everything to do with electrocardiography. A lot of people may not know that syphilis actually has a distinct, or maybe not so distinct after all, we'll talk about that, but an appearance on the electrocardiogram. This is classically what syphilis looks like on the electrocardiogram. This was sent by Dr. Ibrahim, and you take a look at what syphilis looks like. Electrocardiographic syphilis gives you peaking of the T waves. You can get slightly widening of the QRS complex. You oftentimes lose your P waves. The P waves go flat and essentially disappear. You can also end up with a bradycardia here. Now, some of you are probably looking at this and saying, what is he talking about? Syphilis? This is classic hyperkalemia. Well, you are exactly right. This is hyperkalemia. Now, I oftentimes refer to hyperkalemia as the syphilis or the great imitator of electrocardiography. For those of you that know medical history, syphilis was referred to as the great imitator in medicine, and so I refer to hyperkalemia as the great imitator or the syphilis of electrocardiography because it does so many things, and it's such an important thing that we in emergency medicine or any type of acute care medicine, we've got to know what hyperkalemia looks like on electrocardiography. This is the most common deadly electrolyte and metabolic abnormality that we see. And if you make the diagnosis, you can very easily save a life. But if you miss the diagnosis, they can die. And it may not be as common as STEMI, but I think it's just as important for you to know all of the variations of hyperkalemia as you might know for STEMI. Because if you miss hyperkalemia and the patient dies, I would say that's inexcusable because this is a completely treatable disease, unlike STEMI in many cases. Sometimes you can't do enough for STEMI, but hyperkalemia, if you diagnose it, you'll save a life. And so there's just no excuse for not knowing hyperkalemia inside and out, backwards, forwards, left, right, upside down. You've got to know hyperkalemia. So let's talk a little bit more about hyperkalemia or electrocardiographic syphilis. This is your classic hyperkalemia also, right? You see big peaking of the, you see big peaking of the T waves there, widening of the QRS complex, and you see initially prolongation of the PR interval, then eventually the P waves go flat. All right, let's move a little further. This is another example of hyperkalemia, classic hyper-K. There's more widening of the QRS. You'll notice in this case that the P waves are kind of gone, and you can also get ST elevation. That's not something that's commonly taught. In fact, the computer didn't take that class, and the computer called this an anterior wall STEMI. You can also get some ST depressions. You can get a new axis up there, and sometimes it can mimic new bundle branch blocks. Like in this case, this was called an anterior STEMI with a right bundle branch block pattern because the EKG machine didn't know any better. So hyperkalemia can mimic or imitate a lot of other things. In this example, ST elevation, ST depression, new bundle branch blocks. Now you're starting to approach a sine wave type of pattern. You'll know that notice that these T waves are not as peaked as we normally expect. As things start getting prolonged or stretched out, the T waves are not quite as peaked. The QRS is getting wider and wider. Notice again, there's no P waves in there because the P waves have gone completely flat. You've also got kind of a Brugada type of pattern in AVR. That's very, very common. And again, new axis formation up there. This is also classic hyperkalemia. Another form of imitation. Strange, bizarre bradycardias. We've talked about that before on the video cast. And also you can get very, very unusual prolonged sinus pauses on the electrocardiographic rhythm strips and the monitor. What else can hyperkalemia do? You can get strange tachyarrhythmias as well. In this particular case, the rate is probably close to 100 or so. It's very wide, complex. And on the 12-lead EKG, this was sent by a medical student, Zachary Rogers, and the computer in this case called this atrial fibrillation with aberrant conduction. The EKG machine probably thought this was a right bundle. This is not a right bundle. This is just hyperkalemia. Once again, widening of the QRS. T waves, as they get stretched out, are not necessarily all that peaked. In some cases, in some leads, you can have ST segment elevation. In some leads, you can get ST segment depression. You can get new axis changes as well. And also, oftentimes in AVR, a Brugada type of pattern of ST elevation in AVR. How about another case up here? Take a look at this. In this particular case, you've got that Brugada type of pattern in AVR and in both V1 as well. This is very well reported. Again, sinus pauses, very wide QRS, no P wave up there. All right. Another case. This was sent by Dr. Ernie Weintraub, and once again, a Brugada type of pattern in V1 and bizarre wide QRS complexes. No P waves once again. And notice that as things have gotten really stretched out, you really don't have any peaking of the T waves to help you out. You do see some ST segment depression in some leads. You see ST elevation in other leads. And this EKG was actually obtained before the patient ended up having a cardiac arrest because this wasn't recognized earlier. Dr. Weintraub was not the treating physician, by the way, but he sent this case for us to share and to talk about. All right. How about another case? What else can this do? Well, take a look at this. Wide complex tachycardia. The rate here is about 115. It's wide. It's regular. Some people might mistakenly look at this and say this is VTach because it's wide, it's regular, it's greater than 100, right? This is not VTach. VTach must be defined as a heart rate of at least 120. When you see things that kind of look like ventricular tachycardia, but the rate is less than 120, think of hyperkalemia and don't give antiarrhythmics, because if you give antiarrhythmics to this patient, you knock out the sodium channels, which hyperkalemia has already poisoned the sodium channels. And now if you give a sodium channel blocker like lidocaine, amio, procainamide, you will kill that patient. When you see something that looks like VTach, but the rate is under 120, don't call it VTach. Think about hyperkalemia, all right? And again, notice there's a widening of the QRS and in some leads, some ST segment depression. Take a look at this. Now, in this case, this is a wide complex tachycardia that is faster than 120. But the thing that tips you off here that maybe this is not just normal VTach is take a look at how wide those QRS complexes are. We referred to this on one of the previous videos as a regular, really wide complex tachycardia. When you've got a regular, really wide, we call that an RRWCT, a regular, really wide complex tachycardia. When you see that, think of metabolic problems, think of hyperkalemia, and be careful about giving that patient any antiarrhythmics. This was nothing more than simply hyperkalemia. And you'll notice again, it's wide complex. It almost looks like there's a left bundle branch block type of morphology. In some leads, there's some ST segment depression. It also looks like the patient's axis has changed, and just a bizarre type of bradycardia. In fact, the morphologies are changing as you go across here. So again, this is the great imitator on electrocardiogram, and so that's why I refer to this as electrocardiographic syphilis, the syphilis of electrocardiography. And this is something that you've got to know. You must absolutely know hyperkalemia. You have to know all the different variations of hyperkalemia, because if you miss it, the patient is dead. And yet, if you make the diagnosis, there are some very effective treatments that give you a complete save in those patients. Think about all the different things hyperkalemia does. We've all learned about peak T waves. We've all learned about widening of the QRS complex. We've all learned about sinus waves, right? Don't forget, you can get prolongation and then eventually loss of the P wave. You can get advanced AV blocks, bizarre braided dysrhythmia, sinus pauses, ST elevation, ST depression, new fascicular blocks, new bundle branch blocks, new axis changes. It can do just about anything to that 12-lead EKG. It can mimic Brugada syndrome even. You've got to know hyperkalemia. You've got to be on the lookout for hyperkalemia. Be very careful. Whenever you see something that looks like a strange, bizarre braided dysrhythmia, or something that looks like kind of slow VTach, or a regular, really wide ventricular tachycardia, when you see ST elevation that doesn't make sense, ST depression that doesn't make sense, think about hyperkalemia. You're not always going to be bailed out by those peak T waves, which seems to be just about the only thing that's oftentimes taught in medical schools and in residencies, so don't fall for it. Know all the variations of hyperkalemia. This is an absolute must-know, just as important as far as I'm concerned, just as important as knowing how to diagnose a STEMI is knowing how to diagnose the biggest electrolyte killer in emergency medicine. Know hyperkalemia, the syphilis of electrocardiography. If you miss it, there's almost no excuse. You've got to know this inside and out. Anyway, we'll talk more about hyperkalemia in the future. We've talked about it in the past. This is something that we've got to keep talking about so you can see all the different variations. If you have great hyperkalemia cases, send them on in and we'll share them with the rest of the world. I hope that was helpful, and I look forward to talking to all of you next week. Bye for now.